So I wanted to let you know that we did find your two-piece bathing suit at the house, and Mom does have that lotion for you.
Oh, okay. I'll swing by and pick it up.
Yeah, perfect. Cool.
Hey, everybody. Welcome to Guardian Test Prep's Back to Basic podcast. That's right. You might be used to Sights and Sirens. What's that old company? It's not that company anymore. Now it's Guardian Test Prep because we did a name change and it's awesome. And we got all these resources and we're ready to bring them to you. But don't worry, same old brothers. Guardian Test Prep now. Cooler shirts. Have you seen our symbol? It's on this TV. If you're watching this on video, it's pretty sweet. A lot of this was based off of this really cool symbol. This emblem that we have is very cool.
We found a logo that we liked and just decided to rebrand our entire business around it.
So anyway, welcome to the Back to Basics podcast. If you're new with us, what we do here is me, a firefighter, paramedic, RN, IC, and my brother, just an ER doctor. We talk about complicated medical issues, what are sometimes considered to be complicated medical issues. We break them down to the basics, bring them back to basics, make them easy to understand, digestible, and fun.
That's right.
And welcome. Welcome.
Yeah.
Today's topic, actually, do we have any sponsors today?
So we do have a sponsor today. So today's sponsor is Rapid Rescue EDU. So Rapid Rescue Education is a training center, an American Heart Association training center out in Oregon. National Training Center for BLS, ACLS, and PALS. If you're interested in becoming a AHA or Red Cross instructor, check them out at rapidrescueedu.com. They can get you certified online and join their training center to start offering training in your area or to your business or company and that sort of thing. So we appreciate their support. So today's topic is compartment syndrome.
Compartment syndrome.
We haven't talked about this one yet. It's kind of a fun topic to talk about because it's one of these things in trauma that is, I think, interesting to learn about. And
yeah, trauma has a lot of flair to it, but treatment for trauma sometimes is kind of boring. You just kind of cover up the stuff and go. I think compartment syndrome is kind of fun because it's just a little bit of a medical twist on the trauma, right? There's something we got to assess for, we got to look for, we got to be concerned about, and some different ways to handle that, which makes it kind of a little bit more complicated, but fun.
Exactly. And it's one of these things too, like I said, I like you said, sometimes trauma care can be very straightforward in terms of following the trauma algorithm. But this is one of those diagnoses that you have to look for, that you have to diagnose, that's time sensitive, that is a true emergency, needs to be dealt with. So anytime we can ask some extra questions, do some extra assessment to zero in on certain conditions, I kind of get excited because it's kind of more we can do in terms of just generally following our basic trauma care. We're still going to follow our basic trauma care, but maybe we can... you guys can walk away today with some extra things to look for to rule out or rule in compartment syndrome, which is a surgical emergency, which we'll talk about. So
first, let's start with what is compartment syndrome and why is it not crush injury? Because everybody thinks that crush injury and compartment syndrome are the exact same thing. I say everybody, many, many people mix these up. It's very easy to mix these up because they're kind of relative to one another. But what is compartment syndrome? And why is it not crush injury?
So crush injuries can lead to compartment syndrome, but compartment syndrome itself is an increase in the pressure within the tissues, of the compartments of different limbs and things like that. So you get an increase of pressure in the tissues themselves, which can happen from crush injuries, but doesn't always happen with crush injuries. It can happen with a lot of other things as well. The concern there is anytime you have buildup and pressure in a cavity or in a compartment, eventually that pressure can lead to ischemia and necrosis of tissue, right? I think we talk about a lot of things, especially in EMS care. The end-all, be-all is eventually things lead to ischemia, and ischemia eventually leads to seizure, coma, death, right? That's just kind of how things go. So this is another condition where increased pressure within the tissues, within the compartments of the body, can, like I said, if left unchecked, can lead to ischemia.
And then you got dead, floppy limbs. We don't want that.
Exactly. Nobody wants that. So let's talk a little bit about the anatomy, because this is kind of where we have to start. People don't necessarily always remember from your anatomy stuff how the compartments in the bodies work, right? When we talk about compartments. So do you want to talk a little bit about, just from a high level, what we're talking about with compartments in the legs and arms and things like that? So we're mainly talking about limbs here. You can get compartment syndrome of
the problem is the torso. You have cavities, that's different than compartments, but your abdominal cavity could be considered a compartment, or
it'd be very rare to get some kind of increased pressure enough to cause lack of oxygen to the tissues in something like
in
the
your torso,
abdomen.
well, because there's so many other complications that would happen before you get there that would affect your life, right? So like if that increased pressure, you're going to have like heart issues before you're going to have like tissue around the heart that's getting necrosis from compartment. That doesn't really make any
Right.
sense.
So when we talk about compartment syndrome, we're typically talking about the limbs.
yeah,
We're talking about the
so we're
arms,
talking
we're talking about the legs.
or like the hand or the forearm. You know what I mean?
Yeah.
The areas of anywhere that basically fluid can get trapped, or you can have that increased pressure, and it can fill that compartment too much, and then you don't have that outflow, that like safe outflow where you can circulate it back in. So obviously, the closer to the torso, the more serious the compartment because it holds more blood. It's bigger, and you're also cutting off blood flow a lot of times, depending on what's going on. But you can cut off blood flow to the lower extremity then. So like you could have compartment syndrome in your thigh, but then also lose function of your foot and your shin because you don't have blood flow going down there.
Exactly. And the thing is that what we're going to find is that compartment syndrome is typically going to be seen in smaller compartments for the most part, because the smaller the space, the smaller the compartment.
The less pressure needs to happen to increase it to an amount where you have the syndrome.
Exactly. So going back to the kind of the anatomy of like the legs and arms. So like your body is created in a way where you have different compartments that house different muscles, nerves, arteries, and they're separated by what are called fascia. So fascia is this kind of fibrous, firm, kind of looks white. It's like a white tissue, connective tissue type of thing that separates compartments. There's a couple reasons your body does that. One is for something like this, right? We don't really want infection, toxins, blood to be able to go everywhere as soon as they penetrate our skin.
We want to be able to shut off those compartments. And
Yeah.
it's very similar to how like a naval vessel handles like fire or flooding. Like you that's why like if you shoot a torpedo into a battleship, like it can survive that. It's not just going to flood, right? They can shut off those compartments. They can keep the fire contained, or they can keep
Right.
the flooding contained. Shut off those compartments. It's not going to get to the whole ship, right?
Exactly,
So our
right.
body does the same thing, right?
Yeah.
We've got an issue in our hand or our forearm. Okay, well we're going to cut off blood flow to that area and make sure it doesn't affect the systemic system.
Or prevent the infection from spreading to a different compartment, or prevent the toxins that are, that kind of thing. So again, you've got fascia that separates the different compartments to protect us from those kind of things. An interesting thing is that, so if you've ever seen like an infection or trauma to the hand itself, the hand, if you look at your hand, the lines on the palm of your hand are essentially where the fascia connects to the skin. So you got a bunch of lines on the palm of your hand. When you get an infection in your hand, the part of your hand that swells is the top of your hand. And because that's where the actual compartments are. The compartments in the palm of your hand are almost too small. And from a functional standpoint, if you think about it, if you had swelling in the palm of your hands, you couldn't do anything. You wouldn't be able to like survive or handle. So the body's almost made in a way where that swelling and that infection would like go to the top of the hand. So you still
interrupt
can
function so
Yeah,
much.
super interesting. So just
How does
kind
that
of
affect like palm reading?
what's that?
How would that affect like palm reading?
Um,
Like would I still know my future
yeah, of course. Yeah, absolutely. That's a given.
even if it was swollen?
So maybe they're not really palm reading, they're reading the fascial planes.
That's some deep stuff.
Yeah.
We have to dig into that next time.
That'll be next time. Yeah, absolutely. So anyway, so again, fascia is this connective tissue, fibrous tissue. It's firm and it's fixed. It doesn't really it doesn't move around much. And it's good. And like I said, from a biological standpoint, it's good because it walls off different areas to protect our body. The problem is that when we wall off different areas, we now have these compartments that are more predisposed to increase in pressure from, like I said, from whether it's from a crush injury, and now we've got swelling because of blood, or we've got swelling because of fluid extravasation, things like that.
So what I'm hearing is that fascia is more structural, less functional,
Correct.
right?
Absolutely.
But its very structure serves the function of separating these places off in case something were to happen.
Exactly. So really quick, and like I said, I wouldn't necessarily memorize this, but we'll go through it. So the most common compartment affected in the body. So if you're going to get compartment syndrome, you're most likely going to, and this could show up on an exam or something, that's why I throw it out there, it's going to be the anterior compartment of your lower leg.
So like you said, smaller compartment.
Correct.
because it's
Yeah.
more common to have the smaller compartments. You're saying the anterior portion.
Anterior part, which kind of
leg.
makes sense. Like if you look at your leg, like there's not really like your calf. There's a bunch of tissue in the back. In the front, top of your leg, there's just kind of like a lot of times just your bone and like so those compartments are smaller. So the most commonly affected compartment in the body when it comes to compartment syndrome is the anterior compartment of the lower leg. There's 4 compartments in the lower leg. There's the anterior, there's the lateral, then there's the superficial posterior and the deep posterior. And again, that anterior one is the most commonly affected. I don't think you necessarily have to memorize those. I could see it showing up on a national registry exam, to be honest, though. Like, what's the most commonly affected compartment in compartment syndrome? Again, I would just maybe memorize that from a test-taking standpoint. Other most common area you're going to get compartment syndrome is going to be in the forearm. Again, so smaller compartments, but large enough where they can, like I said, cause problems. So the forearm, and definitely don't memorize these. I had to look these up. But the compartments of the forearm are the mobile wad. Apparently that's a compartment. The mobile wad. Then the dorsal superficial and the dorsal deep. And then the volar superficial and the volar deep.
Sounds like races in a fantasy novel.
Yeah, I don't know. Anyway, so again, so like I said, there just recognize that there are compartments in the, like I said, in your lower and upper arm, lower and upper leg. The most commonly affected areas for compartment syndrome are going to be your lower leg. That's the most common one, and specifically the anterior compartment of your lower leg. And then again, next would be your forearm. Cool. So talking about compartment syndrome, what are going to be, maybe you can jump in and kind of tell us a little bit about what are some of the causes of compartment syndrome. Like, so we talked about crush injury is not the same as compartment syndrome, but it can be a cause. When are we going to, from a EMS standpoint, when should we start worrying about looking for signs and symptoms of compartment syndrome?
So I think we have to think of what, like you said, the mechanism of this is an increased pressure in that compartment, right? So what would increase pressure in that compartment? So it could be, this is why crush injury makes sense, right? If something falls on my arm and it forces fluid and pressure to shoot downstream right into my limbs, that pressure is increased, and now I have that risk of that tissue damage, right? You could have some bruising that's causing, like, anytime we have like circumferential pressure, that could be a big issue. So if you had like a real deep tissue bruise and you had that increased pressure and fluid in that area, that could do it. If you had a tourniquet on, that could cause it, right? That's the risk of, like, when we put tourniquets on downstream, we're concerned about, they say, losing the limb, right? Well, it's from compartment syndrome, right? It's from that increased pressure. That's why we want to get that tourniquet off if we can within 2 hours. Get them to the hospital. Fractures can do this.
And that makes sense with fractures because, like you said, you tear some vessels, now you've got bleeding into those compartments.
Yeah, anything that's, so you remember that, like, more fluid is going to increase pressure, right? So if I increase the amount of fluid going into a fixed space, I'm going to increase the pressure in that fixed space. So anything that's going to cause, like, increased fluid, and then the inability of that fluid to escape, though, is the big thing, right? That's where we talk about, like, circumferential injuries that, like, cause, like, pinning, right? So, like, vice-like stuff like that. You could have, we're concerned about circumferential burns.
Yeah, burns as well.
If we have like a burn that then, cuts off that flow because we can't get through we can't escape through that small space because it's kind of banded around it.
So that would be those would be the
anabolic
two
steroids is a big one, right?
Yeah.
Anabolic steroids, if you use anabolic steroids, that can cause increased pressure. So here's my question about that is, do you know, is it where you're injecting it that it's the big risk? Or is it just steroid use tends to shift fluid?
I'm not 100% sure. I think it's where you're injecting the steroid itself, because when you inject anything into the body, it causes a little bit of inflammatory reaction. So if fluid and
so because usually you would inject anabolic steroids in your butt cheek,
right? True,
because it's probably the safest place to do that.
Yeah.
So you just get a dead butt cheek.
I don't know if you can get compartment syndrome in your butt. I'm sure you probably could, but
something to look into.
Yeah.
Next time we'll cover.
Just keep pushing these off. Yeah. We'll talk about butt compartment syndrome specifically.
Butt compartment syndrome.
No, so yes, and I think we can, like I said, all those things, like you said, fractures and bruising, circumferential bruising specifically, like hematomas, like I said, steroid use, anabolic steroids.
So even our own treatments, we've got to worry about, right? Like that's an example. Like if I'm bandaging someone's arm, I want to make sure that I'm starting farthest away from the torso when I band it in a circular fashion up towards the torso. So I'm pushing fluid. I'm not constricting and cutting off blood flow, right? I'm pushing fluid back towards the body to increase that circulation. If I put a bandage on too tightly, again, circumferential issues, right?
Well, and this is why, so when someone breaks their leg or breaks their arm in the emergency department, I don't put a cast on. I put on a splint, because a splint is basically like it's a one-sided cast, if or a two-sided cast, but it allows for that limb to, it's an acute injury, so it can swell. If I put a cast on immediately and the arm kept swelling, I'm going to cause compartment syndrome. So all these things I think can be narrowed down into two main mechanisms. One is increased fluid in the compartment, right? Or two, constricting of the skin, or constricting of the compartment, right?
The compartment becoming smaller. What's increasing the pressure, right?
Right, yeah.
Too much fluid, or the container became smaller.
Right, exactly. So two things. So things that cause, bleeding into the vessels, swelling into the tissue, all this kind of stuff, that can obviously increase the pressure because we've got increased fluid in there. Or things like constricting bandages, tourniquets, circumferential burns, and constricting of that space.
And this is where I have a really big hard time with this a lot of times, because I think of compartment syndrome, and I think when we first understand it in EMT or medic school, like nursing school, wherever, right? We learn it for the first time, and it kind of seems like it's from a lack of oxygen to the tissue, and it is. But we think because there's a cutoff of blood flow, right? Like when I put a tourniquet on, I cut off blood flow. But that's not what compartment syndrome is. What compartment syndrome is that increase in pressure. So a lot of times it's not a cutoff of blood flow, it's a quick increased blood flow, and then that blood becomes trapped, right? Yeah. So that's where we have to kind of, change our thinking, where this isn't from a lack of blood flow. It's from an increase pressure.
Yeah, exactly. Right. And then increased pressure over time.
Because that fluid that's in there, runs out of oxygen eventually.
Right,
and
exactly,
now you get ischemic, and you do get the necrosis, and you have the tissue injury. But that's where it's easy to mix that up. Oh, I'm worried about, and this is where I think crush injury comes into place. We're worried that boulder's been on top of his arm the whole time. We're worried about it cutting off circulation to the rest of his arm, and that's going to go necrotic. Yeah. That's different than compartment syndrome, though. We're also worried about compartment syndrome because of the increase of the pressure that went into that arm from the boulder sitting on it, right?
Yeah.
So,
and another thing too, or when we take that boulder off and all that fluid rushes in there, that can happen as well.
We just cause the compartment syndrome by removing them, right?
Exactly, yeah. So, yeah, perfect. Again, this is kind of like I said, thinking of these things a little bit differently because of how the pathophysiology actually works. So based on what we now kind of understand what's happening with compartment syndrome, so what kind of signs and symptoms are we going to get?
The 5 Ps.
The 5 Ps,
and
right.
The 6th hidden P that you just told me about.
Yes, which I'll share in a moment. But anyway, so the 5 Ps are kind of the easy way to remember what is going on with the signs and symptoms to look for in compartment syndrome.
This is a national registry question, like 100%.
For sure,
by the way.
yeah.
Like I've seen it in dozens of test programs, including our own.
Yeah.
But like if you buy question banks and stuff like that, and you stay in those, like you're gonna see the 5 Ps all the time.
And I'll throw in a little plug here. If you're listening to this lecture and you want to get CE approval for it, then check it out on AmericanCME.com. These our video podcasts are placed on there for continuing education credits, for EMS. So if you want that, go listen to it there. There will be a 10-question quiz, and one of them will definitely be
one of the questions will be the 5 Ps, right. If not two,
or maybe 10, because I can't think of any other questions.
How do you do 10 questions on 5 Ps?
Well, that's the real
which isn't, just over and over and over.
Exactly. So what are the 5 Ps?
Pulselessness. So the area you can't find a pulse. Paralysis. Can't move that area. No function there. Paresthesia, as they say. Which is basically like a numbness, tingling, like a lack of feeling. Different than paralysis. Paralysis would be like lack of function.
Yeah.
Paresthesia would be lack of feeling.
Mm-hmm.
Let me think here. Pulselessness, paresthesia.
Pallor.
It's pale because there's
not new blood flow coming in.
There's not new blood. I love how you said that, because it's not because of a lack. It's a lack. So that's what's funny is it's a lack of circulation of blood flow, but it's not a lack. It's not a cut off of blood.
Yeah, exactly. Yeah.
So
and the last one, pain.
It hurts like hell.
Yeah. And that's one thing to look for. So again, the 5 Ps are great to remember, but then realize that especially in the acute setting, you may only see 2 of them, right? So like I said, late signs of compartment syndrome that pressure's been there for a while, that's what's going to lead to pulselessness, paralysis. I mean, if you have pulselessness and paralysis, that means that the motor neurons have been affected. That means that the blood flow has now been completely cut off over time not because of a lack of blood flow into the thing, but because of the pressure in the compartment has now squeezed down on the vessels that are in the compartment, and there's no more new oxygen and new blood flow coming in. But the early signs, the things that we need to be on the lookout, especially in the acute setting from an emergency standpoint, are pain. Well, that seems a little too easy, right? Like pain's, obviously they're going to have pain. Well, pain kind of out of proportion to exam. So someone who's got like a really painful arm, but you're looking at it and you're like, I don't know, I don't really see any massive trauma there. I don't really see a lot of other changes. Why do they have so much pain? That should clue you in.
Well, and also like, hey, a boulder landed on my shoulder. My bicep feels fine. My forearm is excruciating, and I can't feel my hand. Well, okay,
Yeah,
you know what I
right.
mean? Like
Right, and
you,
like,
you would
obviously-
think your shoulder would hurt just as bad as everything else because a boulder landed on you,
Exactly.
right?
Pain out of proportion. Paresthesias can start early, right? Because you got those sensory nerves that are kind of affected earlier on.
Tingling, numbness, weird feelings.
Yep. And then you're going to, later signs are going to be paralysis, and you're going to get the pulselessness later on, but you might not see those in the acute
What's
setting.
the secret 6P?
So there is a sixth P,
And it's a secret.
and it's a secret that we're going to share with you. It's called Poicolothermia.
Don't know what it means.
Let me tell you what it means. It means that your body can't regulate temperature. So you've got like someone who's like, it's hot outside, and for whatever reason, their forearm has goosebumps.
Yeah, but that's like just a shock symptom.
Oh, yeah.
Why have I never heard of Poicolio?
Because we had to make it a P, so it was 6 Ps. You can't have 5 Ps and an S. You know what I mean? It's got to be 6 Ps.
And shock-like symptoms. And
Right,
fluid
so-
imbalance. 5 Ps and an F.
It's enough. So poicolothermia. So this inability to regulate temperature. We won't dive into it here, but like I remember in medical school, I kind of looked into like why you get these symptoms when you do. If you actually look at the anatomy of like a compartment, where the blood vessel is compared to where the nerves are, it actually makes sense why as pressure build up, certain things would get squeezed down first.
Now, would you see this poicolothermia? Do you think you would see that early as you do in shock? Because like we learn a lot that like fluid imbalance causing that temperature irregularities is a pretty early sign of shock, because that's kind of the first thing that our body shuts down, right? Like our body isn't good at regulating fluid, so then we're cold when we should be hot, we're hot when we should be cold, we're sweating, we're nauseous, things like that. Do you think you'd see that early or late with
I think
compartment
it'd be
syndrome?
earlier. Like I said, I think it'd be earlier. Obviously, pain's going to be your big main one. Paresthesias, like I said, maybe the poicolothermia, and then later would be paralysis and that sort of thing. From an assessment standpoint, a couple other things you can look for. So besides pain out of proportion, another sign or symptom, it would be a sign, not a symptom, but another symptom and something that you can test for in the field is 2-point discrimination. What that means is that I touch you on one part of your arm, and then I touch you on another part of your arm, and you tell me, do you feel both touches? And then I bring my fingers closer together, and I touch closer together, closer together, closer together. In a normal functioning person, like you can tell if like 2 touches really close to each other, you can tell the difference between the two. 2-point discrimination goes away because it's more of like a sensory nerve problem. So you'll touch the patient like on one part of their arm and then like an inch or two away, and they're like, yeah, no, it feels like
I
the
felt
same.
one touch.
Yeah, exactly. So that can be a little bit of I kind of like throwing in some of these, like, what are some other things we can do? People always ask us like, yeah, what other things can I look for in the field? That would be another. That is actually, with the pain out of proportion, a very high yield type of physical exam test to really clue you in, like, ooh, if that's happening.
That's the kind of stuff that's so fun to do in the back of the ambulance, because your crew is always like,
What is he doing?
what are you doing?
Like,
I'm like,
do you
oh,
feel it
2-point discrimination. Don't you know
Like,
that? Like,
obviously.
luckily, we like just did this podcast the day before, but they think I'm a wizard.
Right, yeah.
It's great.
And you're like, is there any poicolothermia? And they're like, huh? You're like,
Yeah, I'm
never
going to use
mind.
poicolothermia. Like,
Never
every day
mind.
now.
Yeah, exactly.
I'm going to ask patients, are you suffering from poicolothermia? And then they're like, I'm like, oh, okay. How long have you been altered? I mean, I know this.
Right, exactly. So again, some extra things you can do from an EMS standpoint. So those are the big things. So the 5 or 6 Ps that we're going to look for. A couple of tests we can do with that 2-point discrimination. So what are we going to do in terms of treatment?
I mean, there's not a whole
There's not a
lot
ton.
we can
There's not a
do.
ton, right? Obviously, as always, and I don't want people, we emphasize this a lot, and I don't want our overemphasis to diminish, you know what I mean? Like what we're trying to say. Early.
You don't want us saying that this is important to make people think that it's not important.
Well, you don't want, yeah, pretty much, right? Like when we keep reiterating something, people are like, yeah, I've heard it.
Beating a dead
I've heard
horse
it.
kind of thing. I get
Right.
it.
But at the same time, like I can't underemphasize how much importance we need to place on early diagnosis. If you diagnose these things in the field because you know about them, you've listened to a podcast, you've taken your continuing education seriously, that is what actually saves people's lives. That's what saves lives and limbs, right? Because if you don't do it, then I got to do it. And let's be honest, like I might miss it too. Like that's why there's a team of us. There's not just one person doing the care from the beginning to the end. There needs to be more people. So again, early diagnosis, or at least early suspicion of a diagnosis that's brought up to the emergency department physician and things like that is so important. So again, don't underestimate how much good you do in the field through just good assessment and good physical exam and early diagnosis of these things. Just because like we're going to give fluids.
Well, that's the thing that's what I was going to say for treatment is careful use of fluids.
Careful use of fluids
is what we would do for compartment syndrome. In the back of an ambulance, we would have careful use of fluids, pain control, and rapid transport.
And trying to figure out what the underlying cause is. Right? Like, is it a constricting, like if someone's basically got these signs and symptoms and they got a cast on their lower leg,
cut the cast
off, right? Yeah, like take the bandage off, like take the tourniquet down, whatever, like these kind of things can happen. We want to assess those and take care of if we can take care of the inciting event, we should try to without harming the patient.
Now, can you explain to our audience why I say careful use of fluid?
Well, yeah, I think it makes sense, right? So like we need fluids to support.
To bring oxygen to
bring
the tissue,
oxygen.
Right?
Now, not really oxygen, because the fluid doesn't bring oxygen, but the fluid itself is going to increase our blood pressure. That's going to increase the flow of red blood cells and
bring oxygen
to the tissues. Right. The problem is we just talked about what are the two main things for compartment syndrome.
Increase pressure. So if I increase the volume, there's an issue. Am I propagating the issue? Right. And this is where I think it's like medics start having discussions of like, well, I wouldn't do that because it could do that, or I would do it every time. And it's always like always never situation, right? So we just have to, it's just like if we have like a cardiogenic shock, like we still treat that patient with fluid to establish a blood pressure. We just have to be very careful that if we start to see worsening signs and symptoms, then we're going to need to back off on that fluid and let people know, let you guys know.
Yeah. So you're not going to start aggressive fluids and let it go and not do anything. You're not going to not start fluids because you're not doing anything. You're going to start gentle fluid hydration and continue to reassess.
And that's the thing is it's this knowing the nuances, knowing what to look for is going to be so important here, because now we're turning the knob on and we're turning it off and we're turning it on. We have to really watch that and know what we're talking about. If we just people want a shotgun method all the time. They want that magic bullet. They want to say, I'll give aggressive fluid management, or I won't give fluid at all. And that's just not the answer. Sometimes the answer is some fluid. Right. And you're not going to know that it's too much fluid until you start to recognize that it's too much fluid, which means you need to know how to look for that, right? And in this case, you're probably going to see an increase in the 5Ps. I mean, you may see swelling even, or you're going to see diminishing vital signs. So just pay attention to those things and back off the fluid when you start bumping into them. Don't chase towards them. I'm going to increase fluid until he feels more pain. Then I know it's too much and I'll stop. That doesn't make sense, right? So it's this knowing the signs and symptoms of it, knowing what you're doing to the body and the negative effects with that along with the positive.
Yeah, no, absolutely. I completely agree. So fluid hydration, early assessment and diagnosis, pain control is going to be huge. Position of comfort, obviously, like I said, that actually does help, you know what I mean? Like putting the limb in a position of comfort. Splinting if it needs to be done. Like if there's a fracture underlying, you need to maybe do a splint.
Yeah, and if you cut a cast off, like put a splint on.
Yeah, right, yeah. Or if they've got, like I said, if they've got trauma and a fracture that you think is causing it, splinting the limb is going to decrease the chance of them causing more trauma and more bleeding into their compartments. So once you bring him to me, what do I do? So in order to truly make the diagnosis of compartment syndrome is a surgical emergency. So we need to be very certain that this is compartment syndrome before we rush this person off to surgery. So what we do is that we take it's a special device that basically sticks a needle into the compartment and measures the pressure. And we know that if the pressure is greater than
turkey baster.
Yeah, kind of. It actually kind of looks like that. No, not really turkey baster. What's that thing you put in the turkey?
That's what I'm talking about. Isn't that called a turkey baster?
No, a turkey baster is where you like squirt the juices.
I don't know.
Yeah. The turkey thermometer thing.
That's what I was thinking of.
Yeah.
A baster.
Not a baster.
What's a baster?
A baster is like where you suck the fluids up with the baster and you squirt it over top of the turkey.
That's kind of...
This is digressed.
Yeah.
Anyway, so
next time, turkey basters and turkey thermometers. How to cook the perfect turkey.
So yeah, the turkey thermometer thing, like it's like a big like metal needle thing that checks the pressure. And if the pressure is greater than, I want to say 20, don't quote me on that, 20 milligrams of mercury, I may be remembering that incorrectly, but something like that. There's some number. If it's higher than that, then yes, that's too much pressure in the tissue.
But he will remember it right if you are his patient in a clinical setting.
I will YouTube that immediately. Absolutely.
Oh, no.
So we get that diagnosis, and then again, it's a surgical emergency. So these patients, what they ultimately need is what's called a fasciotomy. So we talked about that fascia, right? We talked about those fascial planes that keep the current. We need to open them up, right? We need that pressure. It's got to go somewhere. It's got to go out. So we're going to make the orthopedic surgeon usually is going to make incisions to open up the tissue, open up that fascia so that pressure is released.
This is very similar if you guys are familiar with like escharotomies with like third degree burns, right? So we're same danger. That fluid can't escape. Now we're having internal damage to this tissue, so we have to like cut and slice to release the pressure, right? So let that limb or let that compartment expand more.
And the escharotomy is when you have that like burnt, like dark eschar over the skin. But if you have just acute burns and just the acute burns themselves are causing so much swelling that you're getting signs of compartment, you get a fasciotomy. So burn patients will get fasciotomies of their fingers, hands, arm, like whatever they need to be.
And think about this mechanism wise. Either too much fluid or too small of a compartment, right? So what do? We make the compartment bigger.
Right.
And now it's not too much fluid and the compartment's not too small.
Right, yeah.
That's the only really way to handle that.
Yeah, and then too, what from a surgical standpoint, you can go in and if there's bleeding, we can stop that bleeding. If there's, if fluid needs to be
fix that underlying cause.
Exactly, right, exactly. So that's pretty much compartment syndrome. It's not super complicated, but I think again, like you had kind of mentioned, some of these nuances of understanding the real pathophysiology of compartment syndrome, that it's not necessarily a lack of blood flow to the area, it's too much fluid or decreased compartment. So these are the things we have to think about, that we need to ask questions about so we can get to that diagnosis early, because it is, like I said, it's time is limb in this case, right? Like the more time it goes, the worse chance they have of losing the limb because they get necrosis and ischemia and that sort of thing. So anything else you want to add in there before we close out?
I don't think so. Check us out next time for turkey basters, cooking the perfect turkey, anabolic steroids, butt compartment syndrome. I think there was another one.
A lot of topics we got to cover.
We got a lot coming
time.
at you.
Yeah. But we'll do that next time. Another quick plug again, if you would like to get continuing education credits for listening to these podcasts, go to americancme.com. So like this lecture or this podcast won't be there right now if you look today, but within the next couple of weeks. So our past podcasts will be on there. You can listen, get CME credits, see our beautiful faces because it's video based. It's wonderful. americancme.com. Love to have you there. Finally, if you're studying for a national registry exam, you like this kind of content, you got to check out our program, guardiantestprep.com. We have a full NREMT prep program, 15 hours of lectures, question banks, workbooks. We will help you pass that exam, and we'd love to. So hope you guys have a great week.
Doesn't matter if it's AMT, doesn't matter if it's medic, we got you.
Got you. That's right. So we hope you guys have a wonderful week. We thank you for joining us, and we will see you next time.
Stay sweet.
Hey guys, we hope you enjoyed the podcast. If you did, we'd love for you to check out the rest of our content at guardiantestprep.com. We specialize in preparing EMT, AEMT, and paramedic students for not only their school, but also the National Registry exam at the end. NREMT test prep with over 15 hours of videos, workbooks, question banks, and everything you need to pass. We'd love to have you get involved. Again, guardiantestprep.com. Check us out.